Hello, everyone, and welcome to today's webinar titled Revolutionizing Pediatric Cancer Diagnosis and Treatment Through Molecular Profiling. This webinar is a part of the 11th annual event in the Cancer Research and Immuno-Oncology Week virtual event series. I am Kaylee Bach of LabRoots, and I'll be your moderator for today's event. Today's educational web seminar is presented by LabRoots and sponsored by TCAN. For more information about TCAN, please go to www.tcan.com. Before we begin, I would like to remind everyone that this event is interactive. We encourage you to participate by communicating with other attendees using our live chat feature during the presentation. You can find the live chat located at the left of your screen. If you have trouble seeing or hearing the presentation, click on the Help Desk button located at the top of your screen within the event. Now let's get started. I now present today's speaker, Dr. Alanna Church, Associate Director, Laboratory for Molecular Pediatric Pathology Program Director, Harvard Molecular Genetic Pathology Fellowship Chair, Training and Education Committee, Associate for Molecular Pathology, Assistant Professor, Harvard Medical School, Boston Children's Hospital. For a complete biography on our speaker, please find it on the left of your screen. Alanna, you may now begin your presentation.
Thank you so much for your time today. It's my pleasure and honor to be with you today and to work with you on how we can together improve diagnostics and treatment for children with cancer. Every cancer in a child is devastating. Every day in the United States, 47 children are diagnosed with cancer, and over 400,000 children per year are diagnosed across the world. It is the #1 cause of death by disease in children. Over the last few decades, the survival rates for children with cancer have improved. These gains have been made by brilliant, dedicated clinicians and researchers, mostly by bringing caregivers and patients together across the country and around the world, using traditional clinical trials to optimize interventions like surgery, radiation, and chemotherapy. These treatments are harsh. Children go through significant suffering and morbidity during their treatments and often have late effects from these therapies. Unfortunately, these improvements in survival and well-being have not been evenly distributed. So some specific cancer types like osteosarcoma have had no substantial improvements in outcomes since the 1980s. I'm going to speak to you today about what we're doing to try to improve outcomes for our patients today and for children and families who will face this diagnosis in the future. We have several challenges to face when we're trying to advance care for children with cancer. First, each tumor type is rare. Pediatric cancers actually represent a group of ultra-rare diagnoses. And as we're doing more molecular genetic analyses, we're actually subdividing and reclassifying tumors further. We have a Friday morning conference each week with the pediatric oncologists at Dana-Farber. This is the top cancer center in the country with the best team, and almost every week we discuss a patient in our care with a combination of clinical or genetic features that no one in the room has seen before. The second issue is that the pediatric cancer genome is quite different than the adult cancer genome. So we can't always apply the same technologies or principles that we've established in adult oncology to our pediatric patients. Finally, treatment protocols are often designed primarily for adults and often don't include children in trials and with formulations that work well for younger children. Let me share a patient story with you to illustrate these issues. Our patient is a 9-year-old boy. He was previously well. He was brought into our hospital by med-flight after fainting when he was out with his family. As you can see here, he has a large whiteout on his lung, very suspicious for a tumor. He had a biopsy of this lung mass, and the diagnosis was really difficult to establish. On imaging, he also had 3 other masses throughout his body, including one within his brain. We were able to, with our newly opened lab, with a newly designed and validated assay to identify gene fusions, we were able to identify this TFG-ROS1 fusion. So TFG and ROS1 are 2 genes that usually live separately from one another on different parts of the genome, but they have broken off and come together, and they're the driver for this patient's tumor. The identification of this fusion did two things for this patient. First, it really helped us to make the diagnosis. So we made a diagnosis of inflammatory myofibroblastic tumor, which is a rare tumor, but one that we've seen before in children. The second thing is that it helped us to get a targeted treatment for him, which I'll tell you a little bit about. But first, I want to talk about the cancer genome. So this is the view of the cancer genome that I learned about in medical school, and that is still a great fit for describing how adult cancers develop. That a cell that is present in the patient's body will slowly acquire mutations over time through childhood into adulthood, and at some point this cell has acquired enough alterations that it becomes a cancer cell. It reaches a tipping point when it's got just the right amount and just the right way of mutations, and then the cancer cell will continue to evolve on a genetic basis from there. This is actually not what we see in a pediatric cancer genome. We don't see that acquisition of mutations over time and that combination of mutations. We typically see one seminal event, like the TFG-ROS1 fusion in our patient, that alone acts as the driver for the patient's tumor. So back to our patient, he was admitted to the ICU, and because we had that newly developed test, we were able to make that specific and final diagnosis within a week. And the oncologists on our team used the information about the fusion to identify and get access to a matched targeted therapy for our patient. So he began that therapy within 2 weeks of having arrived at our hospital, and he responded really well. So this was a great success story for us. So as you can see, this is the response. Crizotinib is the drug that matched to his fusion. On the left is where we started with him with that huge lung mass. And then after 8 months of therapy on crizotinib, the mass had shrunk down so much that it was really a huge change from the way we began. He went on to get surgical resection of the remaining mass, and really amazingly, under the microscope, there were no living tumor cells left. It was all tumor bed and dead cancer cells. The patient is doing really well. We published a report of this patient and a few others with the same diagnosis who had good outcomes due to molecular profiling. But we also want to be able to demonstrate on a larger scale that these technologies are really helping our patients. Which brings me to the publication of our study last year in Nature Medicine. As you can see, there are so many authors on this paper, so it represents a huge effort at really a national level. The goal of the study overall was to understand the role of molecular profiling for pediatric cancers. So molecular tumor profiling has become the standard of care for many adult cancers, and we typically use adult lung cancer as the success story for molecular profiling, and it has really become the standard of care for those patients. But it's still not routine for children with solid tumors, and there's a lot of variability in who gets access to molecular profiling across the country. All of this was thought through and conceptualized and brought to fruition by my wonderful colleague, Dr. Katie Janeway, who's the senior author on the study. So this study represents the results of the GAIN consortium study, which is a prospective cohort study still enrolling children and young adults up to age 30 years with high-risk relapsed and refractory solid tumors. The study is enrolling patients from 12 children's cancer centers across the United States. This is an overview of how the study works. Oncologists, patients, and their families were consented to the study. Targeted DNA next-generation sequencing was performed on one or more tumor samples from each patient. Primarily the OncoPanel assay, which is a big assay of 450 genes. And we also had some patients with tumors where we thought they may benefit from RNA sequencing to identify fusions who also received that assay. Test results were returned to the treating oncologist, and follow-up treatment and response data were collected. The analysis represents the first 345 patients enrolled on the GAIN study who had successful molecular tumor profiling. The mean age at diagnosis was 11.3 years, and a mean of 13.1 years at enrollment. The largest single diagnosis within the cohort is osteosarcoma, with 19% of patients, and sarcomas together, including osteosarcoma, rhabdomyosarcoma, Ewing sarcoma, and other sarcoma, represent 65% of the patients. Every molecular alteration that was identified in every patient was analyzed carefully by our team. It's difficult to overemphasize the amount of work that went into this project by so many people, including a ton of organization, data collection, and expert analysis. We met every few weeks for a virtual molecular tumor board to review important issues in complex patients. For every molecular profiling test that was done, a report was generated that was sent back to the patient's oncologist. At the time of the cohort analysis, we also re-reviewed every single alteration, first to assess them all at the same point in time, and secondly to evaluate whether there was any change in evidence for matched targeted therapy. Here we're representing our 345 patients, with each figure standing in for 10 patients. We show that 299 of 345 patients, or 87%, had one or more alterations with evidence of clinical impact. Some had alterations that were relevant to their diagnosis, some for their prognosis, some for the treatment options, and many patients had multiple alterations. First, let's talk about matched targeted therapies. What I mean when I say that is that there's a specific molecular genetic alteration which may be associated with response to a treatment that targets that alteration or pathway. This graph represents the specific treatment recommendations made to our patients, according to the gene altered, which is shown on the x-axis, and the class of drug inhibitor shown on the y-axis. Colors represent tier of ICAT recommendation, with 1 being the strongest evidence. The size of the dots corresponds to the number of patients. The pathways we're currently involved in ICAT recommendations were the cell cycle pathway, the RAS-MAPK pathway, and receptor tyrosine kinases. Matched targeted therapies in ICAT recommendations represented a wide range of therapeutic classes. The most common were PARP, WEE1, and BET inhibitors, while the most common supported by high-tier evidence were mTOR, AKT, ERK, EZH2, PI3 kinase, PD1, PDL1, FGFR, and MEK inhibitors. In all, 200 patients with an ICAT treatment recommendation were alive at the time of results and had treatment follow-up and data. Of that group, 40 had been newly diagnosed, and 160 patients had a status of relapse refractory disease. From the newly diagnosed group, most went on to have unmatched treatment or standard therapies, while 5 had matched treatment. From the relapse refractory group, less than half went on to unmatched treatment, and 24 went on to receive matched treatment. Importantly, 20 patients had a recommendation for matched treatment, but that treatment was not available to them. This speaks to another need in the care of children with cancer, which is to increase access to new drugs. I know many people are working hard to advocate for our patients on that issue. Here's another example of a patient, another young boy. This boy was 14 years old and was diagnosed with a very rare tumor, grade 3 neuroendocrine carcinoma, large cell type. He also had a gene fusion identified by our assay, which connects the genes KHDRBS2 to BRAF. He received a matched targeted therapy recommendation targeting the BRAF gene using the MEK inhibitor trametinib. He did go on to receive that treatment and had a partial response that lasted for 5 months. Unfortunately, this patient died of his disease and is one of the patients who helps us to think through the timing of matched targeted therapy recommendations and molecular tumor profiling, and we hope to be able to advocate for patients having this profiling done sooner in their disease course. This swimmer's plot demonstrates each of the patients who were able to access targeted therapy as a result of our recommendations. It includes the 2 patients that we just saw. The top box includes our 6 responders. Notably, the patient at the top continues to do well with targeted therapy for an ultra-rare tumor, malignant glomus tumor. And of the 7 responders, 6 of them were matched to their treatment on the basis of a gene fusion. The 7th was treated with immunotherapy based on alterations in the mismatch repair pathway and a high tumor mutational burden. As a pathologist, I'm particularly interested in the diagnostic potential of molecular studies. I hope you'll agree with me that making the correct diagnosis is a key foundational data point that we need to move forward with the best care for our patients. We were also able to show that molecular profiling had a significant impact on diagnosis across the cohort. As an example, this 14-year-old boy presented with pain in the lower leg, which was evaluated with an excisional biopsy. Pathology was diagnosed as an aneurysmal bone cyst, which is a benign tumor. The mass recurred after a year with the imaging shown here and was biopsied again. The biopsy, seen in C, had pathology with concerning features, and several pathology opinions were provided. One diagnosing recurrent aneurysmal bone cyst, and one diagnosing telangiectatic osteosarcoma. Loss of p53 by immunohistochemistry is shown in D. Gain sequencing identified a novel TP53 USP6 fusion, shown in E, connecting exon 1 of TP53 to exon 1 of USP6. TP53 intron 1 fusions are currently described in osteosarcoma, while USP6 fusions are associated with aneurysmal bone cyst. A TP53 USP6 fusion has never been reported before. A third opinion of the pathology incorporating this fusion result rendered a diagnosis of telangiectatic osteosarcoma, and as a result, the patient received chemotherapy. At the time of data cutoff, he had no evidence of disease 2 years after diagnosis and continues to do well. Altogether, 17 enrolled patients, including this young man, experienced a real-time impact on their diagnosis based on a molecular alteration identified by sequencing. Many of these patients had previously been evaluated according to more traditional techniques, including 8 tumors evaluated with FISH assays. Of the 17 patients with a real-time change in diagnosis, 13 were attributable to fusions, and several were unexpected. We also had the opportunity to look at each molecular alteration identified and evaluate the evidence that it may be significant with respect to the diagnosis. Each one of the 345 patients are represented here according to their diagnostic group. The inner colored ring shows diagnostically significant alterations according to the alteration type. Fusions are represented in green, sequence variants in yellow, and copy number alterations in purple. You can see that there's a lot of green here because most, 77% of the diagnostic alterations were fusions. The outer ring shows where the important diagnostic alteration would have been identified without using next-generation sequencing, using more traditional testing approaches. The dark pink means that the alteration would have been totally missed with older techniques. The light pink shows alterations which would have been partially identified, and the teal shows those that would have been completely identified using other assays. You can see there's not a lot of teal here. Only 4 patients would have had these important alterations identified without next-generation sequencing. These newer sequencing technologies are having a significant impact on our ability to make the right diagnosis. Here's another representation of our patient group altogether, showing the real-time impact the study had on their care. 299 of 345 patients, 87%, had one or more alterations with evidence of clinical impact. 31 patients received match-targeted therapy. 7 patients received match-targeted therapy responded. 6 of the 7 had treatment matched to a fusion. And 78% of diagnostically significant alterations were fusions. Here are some of the key conclusions of our study. Clinically relevant molecular alterations were identified in most of our pediatric cancer patients. They were important for both targeted treatment and diagnosis. And gene fusions are important and common in our patient population. This unconventional trial was able to make important progress in our understanding of the applications of molecular tumor profiling. These results emphasize the importance of fusion detection for patients with sarcomas and rare tumors. Looking ahead, please help me to think about how we can move forward, both within and outside of the traditional framework of clinical trials. Some thoughts I have now about how we can do this. First, we make the molecular profiling tests that we have developed available and accessible to every child with cancer. And we can embrace new technologies like circulating tumor DNA to take our profiling efforts to the next level. Second, we need more targeted treatments, and we need to make sure that they're available to children. This means that people who develop these drugs need to be brave enough to include children in their trials and to create formulations that work even for babies. At the AACR meeting in the spring, we heard from the FDA that they're now open to including real-world data in their approval process, which is wonderful news. Third, I hope that we can improve how we capture and share data so that we can make the most use out of every single unique case that we can. There are great efforts underway at local and international levels, including the Pediatric Cancer Data Commons, to capture the complex and granular clinical and genomic data that we're generating. I'm also fortunate to be involved in a groundbreaking project at the Broad Institute, the Count Me In study, which is funded by the Cancer Moonshot Initiative. This study includes children and adults with cancer who are enrolling themselves, providing their data, their perspectives, and facilitating the use of their own tumor samples to improve our understanding of cancer on multiple levels. I would love to hear from each of you your thoughts about how we can continue to do better. A huge thanks to all of our funders and collaborators, and particularly to our patients and families who shared their information and their tumor samples with us while actively going through their own cancer journeys. And thank you to all of you for your attention today and for your collaboration.
Thank you, Alanna, for your time today and your important research. Before we go, I'd like to thank the audience for joining us today, and I'd also like to thank our sponsor, TCAN, for sponsoring today's webinar. Questions submitted during the talk and the on-demand period will be addressed by the speaker via the contact information you provided at the time of registration. This webcast can be viewed on demand for 2 years until October 7th, 2025. LabRoots will alert you via email when it's available for replay, and we encourage you to share that email with your colleagues who may have missed today's live event. Until next time, goodbye.